Everyone, and welcome to today's MinMD Real Talk webinar, Injection Therapy Online Clinic. My name is Austin Hunt, and I'll be your moderator for this event. I work on the marketing team here at MinMD, and I'm excited to be hosting this session today. Before we get started, we have a short disclaimer that we need to review.
The health and medical information provided during this webinar, as well as the questions and responses from the webinar providers, are solely for informational purposes. This content is not intended to take the place of advice or treatment from health professionals. Nothing presented in the webinar is intended to be used for medical evaluation, diagnosis, or treatment. It is not intended to substitute for your relationships with your own healthcare and pharmaceutical providers. Always seek the advice of your healthcare provider before beginning any new treatment, or if you have questions regarding a medical condition.
All right, with that being noted, I'm pleased to introduce today's presenter, Dr. Amy Pearlman. Dr. Pearlman is a fellowship-trained men's sexual health urologist. Her practice focuses on the restoration of sexual function and urinary control, voiding dysfunction, and the evaluation and treatment of hormone deficiencies, and is located in Iowa City, Iowa. Today, she's going to cover injection medication, syringe and dosing, injection techniques, support options, provide a brief demo, and then hold a live Q&A to close out the webinar. Without any further ado, I'd like to kick things off by welcoming our presenter, Dr. Pearlman. Over to you.
Thank you, Austin. It is so great to be here tonight, and I'm looking forward to tonight's webinar. What do you say? Why don't we start off with some polls?
All right, first question here. How long have you been experiencing ED?
All right, so the majority of people have been experiencing erectile dysfunction for 3 or more years, followed by 1 to 2 years. All right, what's the next question, Austin?
All right, next question here. Have you ever performed an injection on yourself and not received the desired result? Yes or no here?
And most say yes. All right, looks like that's something I'll need to tackle during today's webinar. Next question.
All right, last question here. Have you attended one of our previous MinMD Real Talk webinars? So we run our events, about 12, 16 times a year on various topics.
All right, and the majority of you have said no, so welcome. All right, well, I think we'll just get into it. So as Austin mentioned, my name is Amy Pearlman. I am a urologist, and I specialize in men's health in Iowa City. Most of my patients are men, but part of treating sexual dysfunction is treating the couple, because sexual dysfunction is a couple's disease. So if you're a partner of a man who's been suffering with erectile dysfunction, thank you for joining tonight's webinar as well. All right, to get comfortable talking about erections, I'm gonna light a candle right here and really set the mood, maybe. All right, just let me know if my hair catches on fire. I'll put this back here. All right, get comfortable, folks. We're gonna talk about penises and erections and all that kind of jazz tonight. So really, at the end of the day, it's all about anatomy, and you can't understand dysfunction unless you understand normal structure and function. So folks, that's where we're gonna begin tonight's webinar. The penis in general is a fairly simple organ. It comprises 3 tubes, 2 erectile bodies that fill with blood when you get the erection, and the third tube is the urethra. That's that tube that you urinate out of. And the erectile tissue is actually just like a sponge. So hold this sponge up to my camera right here. This is the tunica albuginea that surrounds the erectile tissue. And this spongy part here that engorges where, when you put it underneath the sink, is what the erectile tissue in the penis is actually like. So when aroused, the nerves surrounding the penis become active, and they secrete, it's all through this nitric oxide pathway. And what happens is through that pathway is that the blood vessels that go to the penis relax. And when you get relaxation of blood vessels, you get more blood flow into the penis. Additionally, that blood makes the penis stiff and hard. Now, the key point here too, and you can I think this is just a really good demo to demonstrate an erection, is when you have these spaces in this spongy tissue engorged with blood, and that tissue expands, it closes off these veins that sit in between this tissue here so that that blood doesn't drain out of the penis. And so that's when we say the erection tightens the veins so the blood can't leave the penis, and that enables the penis to remain erect. So there are a lot of different ways that we can treat erectile dysfunction, and that's one of the reasons why I decided to go into this field, is because I have a lot of tools in my toolbox to be able to do that. And that's by no effort of my own. That's from a lot of research and development and patient education and marketing that's come from companies like MenMD and companies like Boston Scientific and other companies, where they've created all of these pharmaceutical products and medical device products that allow us to treat our patients. We're going to focus tonight on intracavernosal injection therapy, or penile injection therapy, and this is one of many options. When we get into the demo part and the Q&A part, that's where I'm going to get into some of the details and the nuances of how we can potentially mix some of these therapies with other therapies to maximize results. In terms of the penile injection therapy, what all these medications do is they just increase blood flow to the penis to achieve and maintain an erection strong enough for the entirety of sexual intercourse. And that sort of phrase there, the entirety of sexual intercourse, will vary depending on what your quality of life goals are and the goals of your partner. And I think those vary. And too often I don't think couples sit down to say, well, what would be satisfactory intercourse for you, and what would be satisfactory intercourse for you? And perhaps for some men, they might assume that, well, I should maintain an erection for an hour for my partner to be happy. And if you talk to a woman who's going through menopause and has some discomfort down there, she might say 5 minutes. So I would encourage you, if you haven't done this yet, to sit down with your partner to better understand what that actually looks like in terms of both people being satisfied. But when it comes to injection liquid formulations, there are a lot of different things that we can inject into the penis. And the commonly used medications are 3. So alprostadil, papaverine, and phentolamine. And alprostadil and papaverine work to inhibit enzymes, and so that can increase blood flow to the penis, whereas phentolamine turns off the off switch. So when you have, so you get an erection, and that's through the parasympathetic nervous system. And once someone, for example, has an orgasm and the erection is expected to go down, that's the release of the sympathetic nervous system going wild and the release of noradrenaline. And so the phentolamine shuts off that off switch. Trimix is a combination of all 3 of these medications that we just discussed, and Bimix is a combination of papaverine and phentolamine. Now, we have many patients who just use solo alprostadil, a single agent medication. And we'll talk about some of the downsides that are associated with alprostadil, which is why I would say I, for example, put most of my patients on combination therapy with something like Trimix. But you can use solo therapy with either alprostadil, or papaverine. You would not use solo therapy with phentolamine because, again, the phentolamine just shuts off the off switch and doesn't help get the erection. All right, so we have listed here a lot of different formulations for these medications, and whenever I look at the order forms, and let's say I'm training someone in the office and I show them the order form, I think some people become overwhelmed with all the different options, and they look at the order form and they're like, oh my God, I'm gonna kill my patient with Bimix or Trimix. And so it can be as simple or as complex as you want it to be, in all honesty. And when I'm prescribing these medications in the office, I typically start with Trimix at 1 dose, and then we go up on the medication, we titrate it up in terms of how much they're injecting, and then if my patients really want to maximize the injections and get a little creative with them, then I can change the formulation depending on what their results are, or we can go to a different therapy or add a therapy to the injections. But I don't want you to get overwhelmed with all these different things here. I think if you're going to if you're seeing a urologist or someone in the community and the only thing they offer is injection therapy, then they're really going to want to maximize every single way that you can give Trimix because they don't offer some of the other therapies. So just take that with a grain of salt in terms of all these different complex options. Alprostadil can cause this aching sensation in the penis in about 20% of men. And so that's what can limit its use. So if someone just wants to do single agent alprostadil, and let's say they require a pretty high dose, so let's say they're using 30 micrograms, but they really need to use 40 micrograms in order to get a good erection, but they have pain with that higher dose, then they're not going to be able to use that high dose for erections. Whereas if you see with these bimix and trimix formulations, we can lower the alprostadil dose because we have added the 2 other medications. So we tend to see less of that dull ache in the penis with trimix compared to single agent alprostadil. There were a few questions that people asked, and by the way, I just want to say, for those of you who asked questions ahead of time, those were awesome questions and really well thought out questions, so thank you for doing that. There were some questions related to, well, how long should this pain last after the injection? And it really varies because it's not really the pain associated with the actual needle injection, it's more so the pain associated with the medication itself. So I have some patients where, it lasts a few minutes and others where it lasts, 45 minutes or even, more prolonged than that. So in those cases, you might want to try a different variation of the trimix where you might go up on the phentolamine and the papaverin and you go down on that alprostadil dose. In terms of the needles and syringes, you inject this medication into the penis using a very small needle, and the needle sizes can vary in 2 ways. One is based on gauge or thickness, and with needles, the higher the gauge, the smaller the needle. I don't know who came up with these different ways of doing that, but the higher the gauge, the smaller the needle, and also the length of the needle can vary. So let me pull out, get my handy dandy traveling case. Okay. So this is how it comes, exactly like this, and you have the syringe part here, and then you have the needle. And for those of you who, let's say, have diabetes and maybe have to inject yourself with an insulin needle, it's just like that. It's a very tiny needle. So when some patients look at this, and I'll show this in the office so they can visualize what that needle looks like, some people will say, well, is it painful to inject? And I would say, I think some people are surprised at how well they tolerate the injection and the medication, and others are surprised at how poorly they tolerate it. The only way to know is to do the injection. So if there's any question of, oh, should I do it, should I not do it, I find that most people tolerate it well, and then they can just decide whether or not it works for them for the intermediate to long term. But again, you can see it's a very small needle there. And these already come attached. You don't have to switch any needles here. You would just draw it up from the vial using this needle and syringe and inject. Now, in terms of the labeling on this syringe, so it's in like this whole syringe here is 1 milliliter, otherwise, 100 units, or let's say you're injecting, I usually start my patients off with the formulation I use at like 20 units. So that would be equal to 0.2 milliliters. So it's a really small volume that you're injecting. The other point too, and this will address some of the questions that people ask, is if we think about, go back to that sort of anatomy slide when we were talking about the tubes in the penis and that erectile tissue. Let's say this is one erectile body and this is the other erectile body. They're actually connected in the middle by a thin septum. And so you only have to inject one side of the penis, and that medication will actually act in the entire penile tissue. So that's another advantage of the penile injections. You only have to inject one side. You don't have to inject both sides. In terms of the starting dose, the key here is to start low and work your way up slow, which is different from when I counsel my patients when they're taking something like Viagra or Cialis. For the pill medications, I tend, for most patients, to have them start at a higher dose and slowly work their way down, because I find that if you start at a really low dose, let's say it doesn't work and people have these really high expectations that they're going to pop, a sildenafil and have an amazing erection, and it just doesn't happen for whatever reason. They get frustrated, they never make their way up. So for most of my patients, I start high and have them work their way down. But no, you do not want to do that with the injection therapy. On the pill medications, it'll say if you take this medication and you have a painful erection that lasts too long, go to the ER, and that's what we call priapism. It actually doesn't happen with the oral medications when you take them appropriately. It can happen if you take too high of a dose, or if you mix it with something like a medication like trazodone or some other drugs that, that people might use. So that can cause the priapism. But these injections can cause priapism. And I've certainly seen some of those guys in the emergency room, and those patients require that you inject another medication to get it to go down, or actually remove the blood from the penis. So it is key, it is paramount that you start at a low dose and slowly work your way up. Now, depending on where you're doing these injections, oftentimes when they bring you in, they'll do a test injection in the office. So they might start out with 10 units or 20 units and see how you respond to that, and either titrate you up in the office by having you come back for repeat visits, or have you titrate at home. And it all really depends on kind of the staffing and the infrastructure in the office. I'll say in my office, I don't carry Trimix in the office. I order it from a compounding pharmacy. And so I teach the injections how to do it, and then I have my patients do it at home and slowly work their way up. So it's going to vary depending on where you're getting this medication and from whom from whom as well. But the goal here in terms of how much you give yourself and when you know that you're at a good dose is to get a full erection that comes down in a reasonable period of time, and that's the ideal result. So a full erection that doesn't come down requires a reversal medication, means the dosing is too high, and a partial erection that's not rigid enough for the entirety of penetrative sex, mean the dosing may be too low. So it's a little bit of trial and error. And sometimes it may work great, and other times it may not. And you know, part of that reason too is we think about this brain signaling pathway. And for those of you who have seen a specialist before, or have looked, you know, online, we're always trying to tease out, like, well, how much of this is a psychological component and how much of this is a physical component. And I don't think you can really tease them out like that, because if someone feels stressed out, and that guy might not even realize that he's stressed out, maybe he had a, you know, hard day at work and is coming home and is just trying to relax and enjoy the night, you know, with his partner, but he still might feel, his body still might feel stress, and that stress response can prevent those blood vessels in the penis from relaxing. And it can be so strong even that medications like these injections may not work all the time. So that mental health component and making sure that you're addressing whatever performance anxiety and stress that's in your life and getting good sleep is going to be important. And sometimes even injectable medications and other therapies are not going to be good enough to get past some of those other things. So the important notes as well are, don't exceed the maximum prescribed dose without consulting your urologist or whoever is prescribing the medication. And we recommend that you don't inject more than once in a 24-hour period. I usually have my patients, I usually counsel them not to inject more than every other day. And, you know, part of that reason is because these medications, especially the medication called papaverine, can cause fibrosis or scar tissue to develop in the erectile tissue. And that addresses actually a lot of the questions that some of you asked. Is you've noticed some changes in the tissue of your penis. Maybe you're developing some penile curvature or scar tissue, or maybe it's just not stretching as well as it used to. And that can happen with papaverine. And so that's why we recommend to not, you know, inject any more than really every 48 hours or so. So let's talk about some demo and actually how to do this injection. So to prepare for the injection, you want to gather your supplies, prepare the medication, and then go in for the injection. So let's go back to my travel case here. All right, so this is the medication vial. As we discussed, this is the syringe, and then you'll have some alcohol prep pads. I don't think I have to explain what this is here, but this is a penis for anyone not aware. All right.
If we're doing this right now, Dr. Pearlman, I would suggest stopping sharing your screen so we can go full webcam so we can see. Yeah,
I'm just going to do the demo. I'm going to go off script here a little bit. Sorry, Austin.
You do you.
All right. All right. Am I good?
Yeah, right. Good to go.
All right. So let's say I'm going to start my patient at 20 units of Trimix. So I'm going to go here to 20, and that's just air there. All right. So then I'm going to put this needle into this vial. inject the air in, and then I'm gonna pull back and get that so that it's at 20. And I see there's a little air in here, so I'm just gonna kind of go like this a little bit. Maybe I'll push some of the air back into the vial and then make sure I'm back at 20. All right, take that out here. And someone had also asked some questions about, when they inject, the needle might bend. So you just have to be careful that when you're putting this in and drawing the medication out, that you're doing it at a 90-degree angle, because it is a tiny needle, so it's pretty flexible and you can pretty easily bend it. I did see one patient where the needle came out and stayed in his penis, which was not ideal. So just be careful and make sure that you have good injection technique when you're getting the medication out of the vial and then injecting. But it's always good to try to inject at a 90-degree angle here. All right, so you have the medication all drawn up in the needle. You're gonna take that alcohol swab, and then you're just gonna kind of put it around this area here where you're planning to inject. Now, the goal here is to inject on sort of either side of the penis at like 10 or 2 o'clock. And you don't want to inject on the top part of the penis here, because that's where the dorsal neurovascular bundle sits. So there are that's where the nerves are, and you have blood vessels up there. So don't inject like that. And you also don't want to inject down here on the bottom part, because remember, that's where your urethra is, that tube that you urinate out of. So the sweet spot is going to be at 10 or 2 o'clock. And if you can, we do recommend that you alternate sides, again, to kind of spread out where you're doing the injection, as you can develop some of that scar tissue. And then we want you to inject towards the base of the penis. So not towards the tip of the penis, not in the middle of the penis, towards the base of the penis. And so I would put the needle in right here. And you want to also look, sometimes people can have quite large veins on the side of the penis. So try to avoid the large veins. You hub the needle in all the way, and then you slowly inject. Okay? Take the needle out. You're going to put it in the handy dandy sharps container. And then you're going to hold pressure here on this area. You can use your alcohol swab or just your finger and just hold it there for 1 to 2 minutes. Now, if you accidentally hit a blood vessel, or let's say you're on blood thinners, you're going to be more prone to bleed after an injection. It doesn't mean you can't do the injections. It just means you have to be aware of the increased risk. So hold pressure. If you move your finger and you notice some oozing of blood, then keep holding pressure until that bleeding stops. I do recommend that my patients too keep standing after their injection. Due to gravity, it might keep some more of that medication in the penis. But then also, if we think back to the mechanism by which the injections work, they work via a different mechanism than the oral medications like Viagra and Cialis. And so if you do the injection and you stimulate yourself, whether it's looking at something, thinking certain thoughts, or manually touching yourself, then you're going to be activating the nitric oxide pathway as well, in addition to the other pathway that we stimulate with the injections. And so both of those can actually help give you a better erection too. For some people, if there is an issue, like a concern with your body habitus, let's say you have a larger belly and you just can't see that well, then I would recommend that you go in front of a mirror to get a better look. But also, if you have this conversation with your partner, you can really use this as part of foreplay. And I always find it interesting when we think about how sexual scripts change as different situations arise and as people get older. And perhaps if you think about what your sexual script looked like. So a sexual script is how you go from a non-sexual environment to a sexual environment. So let's say when you were in your 30s and you were with your partner and you were both in the kitchen and came home from work, maybe you said something like, "Hey babe, do you want a glass of wine?" And then even though you were just asking if that person wanted a glass of wine, you kind of both knew where this night was going, and it set the scene for what was going to happen. But then let's say you're now in your 60s and you were treated for prostate cancer at 58, and now you're 61 years old, and it's just not that easy anymore to get an erection, and maybe you're using the penile injection therapy. Get a little creative with this. And so maybe now your sexual script looks like, hey babe, you want to give me an injection? Or hey babe, you want to go grab the vacuum pump? So I know it's going to sound a little bit awkward and it's something to get used to, but you just have to be aware that the sexual scripts change and you can get a little creative in terms of how you talk about foreplay and change from a non-sexual to a sexual environment. But if your partner, as part of that foreplay, can also do the injection or use the vacuum pump on you. All right, so we already kind of went through this. Sorry, I went off script a little bit. All right, let's talk about side effects. So the key, as I briefly touched on, is to use proper injection technique, and a lot of people will do that first dose in the office to make sure you know how to do that. And that can also help sort of, set which dose you're going to start out. In general, like if my patients are not getting any erections with Viagra or Cialis or anything else that we've tried, and I'm starting them on injection therapy, I might start them on a higher dose. So for the Trimix formulation I use, it might be 30 units, for example. Now, let's say I have another patient and he gets a partial erection with 100 milligrams of sildenafil. Then for that guy, I might start him at a lower dose because he is getting some erections. But in general, if someone's coming in and they haven't done any injection therapy before, I'm definitely going to start them at a lower dose. And then in terms of going up on the medication, for the typical formulation that I use, if I'm starting them at 20 units, I'll have them go up by 10 units each time. So let's say on a Monday that person injects 20 units and it doesn't provide great erections. Then on Wednesday, he goes up to 30 units. If that's not quite doing the trick, on Friday, he goes up to 40 units and goes up to the full 100 units. But this will depend on the concentration of each of those medications that are in the formulation. So these are questions you're going to want to ask the pharmacist and or the prescribing provider. Let's see. Punctured or sealed vials must be refrigerated. In this travel case here, it actually does come with a cold pack. So this is something to keep in mind if you're traveling, that you do need to make sure that this medication stays cold. The single agent medication, Alprostadil, usually comes in something that's not pre-mixed. So you mix the pellet with the diluent solution. And so those can actually stay at room temperature. So those, I have some patients who might use those to travel, and then they use Bimix or Trimix when they're at home and can keep it in the refrigerator. And then in terms of Bimix and Trimix, the multi-use vials, they're safe to use up to 28 days after the first puncture. We get asked all the time, well, what happens if I use this medication after that 28 days? Well, let's just put it this way. As far as I'm aware, some of my patients have used it past the expiration date. As far as I'm aware, none of them have died from doing that, but I can't give any recommendations that are sort of off-label from that recommendation of 28 days. So the safe thing to do, for your safety and for efficacy of the medication is to follow the guidelines on the packaging in terms of expiration dates. And then in terms of injection accessories and help, as I showed you, there are options on the MenMD site for a nice travel case, and there's an auto injector that you can purchase, and this comes with that cooling kit to keep it cool, and the vial, and then I showed you the syringes and needles previously, as well as the alcohol swabs. And then you definitely want to get something to hold these needles so that you don't cause yourself or anybody else any harm once they're discarded. Do not reuse needles, please. That would be poor form. All right, so for more information, MenMD clinical case managers provide answers and insights to your questions. We have the link here for the portal as well as their phone number to request a clinical case manager. And then we're going to get into a little bit more of this demo section and address some of those other questions that people asked.
All right, before we do that, we'll just have you stop sharing your screen. We'll go full webcam for the Q&A session.
All right.
All right, looks like we're set. All right, first question here. How often is it safe for me to inject?
So we recommend every other day. And let me just say too, okay, this saying, if any of you have heard this, if you don't use it, you lose it. No truer words have ever been spoken. And I wish that more of my patients were told this early on. When you're young, you're 20 years old, and you probably don't even wake up, they just happen, where you get several nighttime erections. That is your body exercising the tissue in the penis without you having to do anything. And then as you get older, and let's say you have high blood pressure, or diabetes, or pelvic cancer that's treated, and you're no longer getting those nighttime erections, that tissue is no longer exercised. And so what I tell my patients is my goal is to get you as good erections as possible, as often as possible, with the caveat that that doesn't give you permission to bother your partner for all of those erections. This can be done for yourself and the health of your tissue. Just like if you go to the gym, you're not working your biceps for anybody else but yourself, okay? And so with these medications, even if you're not gonna have intercourse Monday, Wednesday, Friday, you know, and maybe it's you plan on having intercourse once a month, I still do recommend that you stimulate the penis, you get good blood flow to the penis, however you need to, as often as possible. And with the injections and that possibility to develop some scar tissue, we usually recommend, you know, every 24 to 48 hours.
Next question here. Is there any help for men with a needle phobia?
So, you know, I would never force injections on anybody. And that's why I think it's really, it's a good idea to hold the needle up in front of the person, you know, in person, to say, this is the exact needle that you will use to inject. And then you just look at their eyes. And even in the COVID era, we have the bottom part of our face, you know, covered, but you can still see the expression in the person's eyes. And if those eyes are going like that, then maybe that person should not do injection therapy. And you know what? That's okay, because we're going to get into some of the other options too to treat erectile dysfunction. If you really have a needle phobia, which is not, that's okay. It's not abnormal to be against injecting your penis. That's like a normal reaction to this therapy. You don't want to traumatize yourself. So you got to do whatever feels comfortable to you.
All right, next question here. At my age of 68, is it possible to impregnate a woman? Is this something that I need to be worried about?
It's possible. If you really want to know, you can get a semen analysis to see how much sperm you have in your ejaculate. But yeah, I mean, if you are able to ejaculate and you haven't had a vasectomy before, it is still possible to impregnate a woman.
Good to know. Is there any other way to determine proper dosing other than trial and error?
Folks, sometimes that's just kind of how it goes, is listening to your body, and it might vary. So there were some questions like, well, how come sometimes 40 units works and sometimes I need to use 60 units? And it's the variability of the body, and you can't always predict how it's going to work. And these other factors of like poor sleep and stress can affect how well those blood vessels will expand. So no, it's starting at a low dose and then slowly working your way up.
Okay, next question here. Why do I have to keep using more medicine every time I inject? Am I building a tolerance?
So it's not necessarily that you're building a tolerance, but it's that medication, the papaverine, can cause some scar tissue. So we do see in some folks that with repeat use, it doesn't work as well as it used to. And that's that sponge right here, and you have scar tissue sort of just develop here, which may not be a plaque that you can really feel. You know, for someone, so I see, you know, men all the time in my office, so I can feel when there's scar, and you may not even notice it. It might come on sort of in a subtle fashion. But yeah, it just doesn't work as well when you get that development of scar tissue.
Okay, yeah, piggybacking on that, should you continue to inject if scar tissue builds up?
It all depends. So I treat penile curvature as well. So for someone coming in who, let's say, has penile curvature and has scar tissue develop, I typically don't recommend continued injections in those people because I know it's not going to be any good for their penile curvature. So it's all based on this shared discussion. And The other options that I would consider in those who form pretty significant scar tissue, and if the injections, just aren't working that well, would be something like a penile implant, which we'll get into in a little bit. But if you're like, I want a penile implant and I want to maximize injections and I'm okay with the risk, as long as you understand the risk, then you can continue injections.
All right, so you touched on this earlier, but here's a question around losing length over the years. After years of not using it, it seems to get smaller and smaller. Is that normal? How do I regain my length that I've lost?
Yeah. So I would say it's not normal, but wow, is it incredibly common. It's one of the most common things that I hear people say. And, part of it, we'll grab this guy here. So part of it is, as people get older, they tend to accumulate fat in different areas. And so one of the things is oftentimes I see guys that have a suprapubic fat pad here. And these erectile bodies are connected to the pubic bone, so they stay in place. But when you have extra fat here, it'll cover the penis and can actually bury the entire penis if there's significant tissue on top. And so that's part of it, is I'll put the penis on stretch and I'll push the fat back. And you can actually tell that a lot of guys have normal length. It's just their extra fat on top can cover that tissue. But the other thing too, as I mentioned, is if you don't stretch out that tissue, in a long time, the tissue changes and it doesn't stretch as well as it used to. So let me give you an example. I have two sponges here. So let's say it's January 1st, 2021, all right? And I put both of these sponges underneath the sink and I turn the water on. And I take both of these sponges and I wring them out. And sponge number one, I just put on the counter and I say, you know what? I'll see you back January 1st, 2022, all right? And I don't do anything with it. Just think about what that sponge is gonna look like. It's gonna be dried up and shriveled, okay? So if I put this sponge, January 1st, 2022, under that faucet again, a year later, just think, is it gonna expand like it did a year ago? The answer is no. If I take sponge number two and I put it under the sink, I wring it out Monday, Wednesday, Friday for the next year. I put it under the sink, I wring it out. I put it under the sink, I wring it out. Think about what the health of this sponge will look like January 1st, 2022. A lot healthier. It'll expand a lot more. Folks, that is exactly what we're talking about with the penis. The key is to get good blood flow in the penis as regularly as possible. Now, whether that's with oral medications or injection therapy, another thing too that can be really useful is a vacuum pump. And these vacuum pumps, you can use them for sexual activity. So if you're using it for sexual activity, grab. Don't ask me why I have so many penile demos here, but all right. So this vacuum pump, you would put around the penis here. This one is a battery powered one. So then I would go like this, and I don't know if you can appreciate this here, but it's expanding the tissue, right? And you can see that it's expanding the tissue. So if you want to use this before sexual activity, then you would take a tension band. Tension band, which is something like this, and you would slide it off the end of the vacuum pump and onto the base of the penis to keep the blood in, all right? And then you could use it for sexual activity. But where I have more of my patients using the vacuum device is for penile rehabilitation. And that's where you put it on here, you stretch out that tissue, you try to keep it on for a few minutes, you can do it several times a day, and you don't use a tension band in those cases, you're just really trying to expand the tissue. I started recommending these vacuum pumps just like 6 months ago or so, and I'll tell you, my patients have really benefited from this therapy. So if your concerns are that you really want to prevent loss of length, loss of girth, stretch out that tissue, And if you're not getting regular nighttime and morning erections, I would highly recommend getting a vacuum pump. There are a lot of different vacuum pumps out there. I tend to find that patients do better with a battery powered one. You want to get a good piece of durable medical equipment. It's like when you walk into Walmart and you're looking for a mixer to make protein shakes, and you go down that aisle and there are 30 different options, and you're like, can I get away with the $20 one, or do I need the $400 one? And it becomes so overwhelming that you leave with nothing. So I would say you don't always need the most expensive one, but you shouldn't get the cheapest one either. And I know MenMD has some products on their portfolio. This one's by Gesiva Medical. So I would recommend getting a good product because you'll use it and it'll actually work for you.
All right, I have another question here following up on the VEDs. Does vacuum therapy help with penis curvature?
So a vacuum pump will not help with penile curvature. I do have another device here. This is a traction device. Now this one is a Restorex device. Now, I don't get any money off of promoting any of these products. I just know that my patients like these products, so they're ones that I have demos for. But with penile curvature, I still recommend a vacuum pump because penile curvature is a shortening disease. It's development of scar tissue. And so really, if you want to minimize loss of length and girth, then a vacuum pump can be used in conjunction, but it's not necessarily used to fix curvature. A traction device can be used, you would put it like this and clamp the penis here, and then you can bend it, in the opposite direction. We oftentimes use these in conjunction with penile injections. So not the penile injections we're talking about today, but penile injections like Xiaflex injections to really put stretch on the tissue. But these traction devices can also be helpful for use in conjunction with like a penile plication procedure, or if you're having a grafting procedure. So, if I could have all my patients who come in, to come in with, if they're coming with penile curvature, erectile dysfunction, I wish all of them would get a vacuum pump and a traction device and whatever other therapy we're using, because they all work a little bit differently and can have their own advantages. This is going to really stretch out that tissue and engorge, the spongy tissue with blood. Now it's venous blood, it's not well oxygenated blood. And this is going to maintain that penis on stretch. And you can even, put it out on stretch straight out to help prevent loss of length, for example, like after prostate surgery. So these tend to work well with patients, but it's a process. And some patients are going to be really motivated to use these products, and other people are going to be like, look, I'm not really down to use all these things. It seems really inconvenient, like, no, thank you. And that's okay. Tonight is just talking about all these different options so you can decide, what works for you and what works for your budget.
Absolutely. And to the point that you brought up about the Restorex, we actually had a webinar with the Restorex company. So if you're interested in learning more about Peyronie's disease and the treatment of that, we have the video available on our website on demand as well as on our YouTube channel. So if you're interested, go there, folks. It's a great webinar with the inventor of the Restorex product. Next question here is post-prostatectomy ED a lifelong condition?
So I would never expect someone who has treatment for prostate cancer to have better erections after treatment for prostate cancer. And the reason is, and we're not going to get into the conversation of who created us, but the anatomy was poorly designed. So if we look at a cross section of the male pelvis here, you have the prostate, and the nerves that are responsible for erections are plastered on the prostate. So during prostate surgery, depending on how aggressive your disease is, a lot of surgeons can peel those nerves off of the prostate tissue. But even no matter how careful the surgeon is, those nerves are going to have some damage after surgery. And it can take up to 2 years for those nerves to recover. Now, let's say the prostate cancer was locally advanced and they couldn't spare the nerves. If you had a non-nerve sparing prostatectomy, then the pills will not work. The pills rely on the nitric oxide pathway, and nitric oxide has to be released from nerve terminals to get erections. So for guys who have had non-nerve sparing, those are guys I'm going to be a little bit more aggressive with, especially early on. We're going to, do more of like vacuum pump, which you can use in conjunction with the penile injection therapy, because the injections, they don't require good nerve function. So that would be, another thing to consider depending on what type of prostate surgery you had. But after prostate surgery, let's say you did have, one side nerve sparing or both sides nerve sparing, then your erections may get better over the course of 2 years as those nerves continue to get better. So let's say 3 months after surgery, you're requiring injection therapy. All right. And then 6 months after, you notice that you don't require as high of a dose and you're going down on the dose. I would say that's really reassuring and those nerves are getting better. And then maybe after a year or a year and a half, then maybe the Viagra or the Cialis will work for you. So it really all depends on how well those nerves will recover. But a main predictor of post-prostatectomy erectile function is pre-prostatectomy erectile function. So if you're coming into surgery and you have a rock hard erection, no issues, don't need anything to help with erections, then you are likely to have better erections after surgery, or better than someone who doesn't have good function before surgery. If you're coming in and you're already requiring penile injection therapy, or you're requiring high dose pills for erections, then those pills are, might not cut it after surgery. So, there's no data to say that penile rehabilitation with a vacuum pump, injections, daily Cialis, any of those therapies will get you back to what you were before your prostate surgery. But these therapies can treat your erectile function. It just you may not ever get sort of off these therapies, if that makes sense. It all depends on how well your nerves recover and if your nerves were able to be spared. But to go back to my point from the beginning, there are very few men in whom we can't restore function. And the reason is because we have the pills and the vacuum pump and the injection therapy, but we also have penile implants. And I know there will be another seminar focused on penile implants. But penile implants really don't rely on any nerves or blood flow. Basically, we're replacing the hydraulics in the penis. And so we put something like this in here. So each of these cylinders goes in each erectile body. You have a pump that sits in the scrotum. We don't remove testicles for this operation. There's plenty of room in the scrotum. And so we put the pump in between the two testicles. And then you have a storage reservoir that sits in the pelvis. And so when you want to get an erection, you just push this pump here and you're moving fluid from that reservoir through the pump and into the cylinders, and you can maintain the erection for however long. So I'll say, the guys who are good candidates for a penile implant may be those who have tried something like Viagra, not doing the trick, even with vacuum pumps. And let's say either don't tolerate injection therapy, have side effects from injection therapy, or starting to notice, some scar tissue to develop. And those guys can be really good candidates for penile implant surgery. But really, with our updated national guidelines, the American Urological Association guidelines, which everyone has access to as well, it's no longer that you have to fail everything before you make it to injections or penile implants. And we have plenty of patients that try something like, an oral medication, it doesn't work, they go to penile implants, or medications plus injections plus vacuum device, and they sort of find their way. So I think the main point with a lot of these therapies is you figure out, well, how can I hurt my patient? And once you understand how you can hurt someone, then everything else is fair game. We don't want to hurt anyone, but there are ways to be creative. So another one of the questions was, well, when can we combine therapies? Absolutely. So you can combine pills with a vacuum pump. You can combine pills with a tension band to help maintain the erection. You can, let's say you can combine, and this, it depends on, you gotta, not everyone will say this is okay. It's definitely going to be used off label, but I have patients who take a little bit of a Viagra or Cialis and they combine it with some injection therapy because those two medications are working via different mechanisms. So you just have to be careful. At the end of the day, it's really going to be based on your prescribing provider and what their comfort level is. But, you know, I've had just kind of plenty of patients come in and they say, hey, doc, you didn't tell me to do this. I did it and it worked great. Is it okay if I can continue doing that? The answer for a lot of those patients is if it's working and you're doing fine, you're not hurting yourself, yeah, you can. In terms of combining therapy too with the injections and vacuum, you know, we have some patients that prefer to inject the medication first and then use the vacuum pump. Then there are other patients that will pump first and then use the injection therapy. I did have a patient recently say he got much better results in sort of like evening out of the injection medication when he pumped first and then did the injection. I think that's a really good idea. So there's no right way to go about it. Be a little creative, experiment a little bit, and see what works for you.
Okay, covered a lot there. Next question is, my trimix works, but I've lost a lot of sensitivity and it takes a long time to climax. Why am I having issues climaxing?
So that can be related to a lot of different things. And you want to look at your medication. So we have some patients that are on medications that are known to prolong orgasm and ejaculation. And a lot of the culprits there are going to be SSRI medications for something like depression. So you want to look at the medication list. The other thing too that can be important, and I know, Austin, you said that you guys are going to roll out some webinars on testosterone therapy. And testosterone therapy is really important. So, you know, if you have low testosterone levels, it's really hard to get a good erection. But it can also, depending on testosterone levels and estrogen levels and prolactin levels, if those are out of whack, it can also affect the ability to orgasm. And so I'll oftentimes check hormone levels in guys who are having issues with orgasm and ejaculation. The other thing too with sensitivity, I mean, that can happen with diabetes. Diabetes affects the nerves, and so you can have decreased sensitivity, or any back issues, decreased sensitivity. I've heard also with the medication, sometimes that can affect sensitivity. So another product that I recommend some of my patients is using like a vibrator, and there are vibrators that are specific for men. Tenuto, TNUTO is a product that I've heard good things about. So we think about vibrators for women. Fellas, get a little creative here to try to stimulate those nerves. You're not going to hurt anything by doing anything like that, and see if that works. But yeah, sensitivity issues can certainly be an issue for some folks, and I oftentimes find that it's related to medication use too, diabetes.
Perfect. Next question here. If I still have an erection on a 4 to 5 scale after about 4 hours, do I need to go to the ER?
So it depends if it's a painful erection. You definitely are going to want to go down on your dose next time. I would say, you know, hopping in like a cold shower, putting some ice on the area. You know, if you haven't orgasmed yet, you know, trying to get that going. You know, sometimes people will take like a Benadryl, you know, something like that, which, you know, for some folks can help. But I would say, you know, if you're getting at like that 3-hour mark and you have a really painful erection that's rock hard, I'd start making your way to the emergency room, because depending on what ER you're going to, it could be quite busy and might bring you past that 4 hours. If it's about 4 or 5 and it's not like very painful, then you don't necessarily need to go to the OR. Sorry, you don't necessarily need to go to the ER for that. But there's not really a great answer. I say if guys are rock hard in the ER at like that 4-hour mark, I worry about those guys, because I know they're not getting good oxygen to their penis. But if you're at a 4 or 5 and it's not painful, then I don't think you need to go to the ER for that. Try a cold shower.
Next question here. How old is too old to continue injection therapy?
You are never too old for injection therapy. I have guys who come to see me in their 90s and they ask the same question: am I too old to worry about my erections? And my response is, if not now, when? So if sex is important to you and sexual health is important to you, and if it's important to your partner, then it's important to us to treat it. And I have plenty of my patients in their 60s and 70s that are healthier than the guys in their 30s and 40s who come to see me. So age really doesn't play much of a factor for most of us who specialize in this disease process.
Next question, when I'm standing up, I have an erection after injecting, but when I lie down, the erection goes away. Why?
Yeah, and that can be, that's why I do recommend that my patients stay standing due to gravity. It can help keep that medication in the penis. But some people are just very positional. And so whatever sort of position works for you in terms of the effect is fine. But I do actually recommend that my patients stay standing and stimulate themselves. And that tends to work pretty well. The other thing too that I want to touch on that I haven't really discussed yet, my last demo on my back table here, and this is a female pelvis, but I think it highlights this point well. Look at all of the muscles in the pelvic floor, and the pelvic floor muscles are really important, and we never talk about them, right? When we talk about muscles, we think about our biceps and our triceps and our traps and all those kinds of things, right? But we poop through our pelvic floor, we pee through our pelvic floor, and our pelvic floor muscles also surround our erectile bodies. And I send a lot of my patients, if you're coming in and you have any type of like genital pain, testicular pain, penile pain, sexual dysfunction, urinary urgency, frequency, straining to urinate, sure, it could be a bladder problem, it could be a prostate problem, but if you're coming in with several of those symptoms like post-void dribbling, where you kind of dribble a little urine after you pee, oftentimes we find that people have pelvic floor dysfunction. We think about females and pelvic floor. Why? Because we shoot babies out of our pelvic floor. But men have pelvic floor dysfunction as well. And if you go to like a pelvic floor physical therapist, they can teach you exercises that can help with urinary control and also sexual health. And I've been amazed how many of my patients have come back who have done pelvic floor physical therapy and their erections and their orgasms have improved. You can think about what happens when you orgasm and ejaculate is that it is a rhythmic contraction of the pelvic floor muscles. So if those pelvic floor muscles are discoordinated, they're too tight, they're not working well, then that can cause pain with ejaculation and might discourage you from wanting to be in a sexual act. So pelvic floor physical therapy also plays a role, especially if you've had prostate cancer and have been treated for that.
Okay, looks like we just hit the 8 o'clock mark. We've got a few more questions here if you want to answer a few more.
I think what we'll do, I think we'll end it. And then I think you and I had discussed doing a little rapid fire questions so people can go back to those. And I'll give like 1 to 2 answers for each of these questions to make sure that we address them all. I don't want to bore too many people tonight, but I hope the message from tonight's session is the following. If sexual function is important to you, it's important to us. And we have so many therapies. It is no longer the days where the only thing we can offer patients is oral medication. So if your provider is saying, oh, well, let's go up on the Viagra. Oh, there's nothing else I can offer you. You have to find someone who will give you total solutions. With the vacuum pump, the injections, the penile implants, there are very few men in whom we can't restore function. And I encourage you to rewatch this webinar, look through the MenMD site. I tell my patients, you're gonna have to watch these videos 10 times before you understand what I'm saying, and another 10 times before you decide what to do about it. There are rare things in medicine where we actually give our patients the choice to decide what to do. And so for a lot of men, when it comes to these decisions, it can be overwhelming and you just don't know what you want to do or what works. And that's okay. We understand that. So just, read whatever you can, look at the handout that's attached on the injection therapy and ask questions. And I appreciate your time. Austin, high five, man.
Air high five, virtual. Well, yeah, to your point, we'll do the rapid fire Q&A and we'll be posting that next week. So everybody who did not get their question answered, we will most likely get to it or a version of their question next week when we do that rapid fire. But with that, I'd like to thank you, Dr. Pearlman, for taking the time to present today. We'd also like to thank everyone listening in for attending this MenMD Real Talk webinar. We hope it was informative and you'll join us again for our next event. We've got a lot coming up in 2021, so stay tuned. But if you'd like to learn more about injection therapy, you have a few options here. As I mentioned in the introduction, we've attached the injection therapy guide to this event. So if you'd like, you can download that PDF for your reference later, and that is going to be in the Handouts tab in the control panel. There are also more resources in the Resource Center on minimd.com. Visit this page to view instructional videos, guides, expert articles, and more. We'll also be posting the rapid fire Q&A in there as well, so you can go there to view that. You can also call MinMD at 857-233-5837 or log into the password-protected secure MinMD portal to schedule an appointment with a MinMD clinical case manager. If you're interested in injection accessories, you can learn more or purchase accessories on the shop page in the MinMD portal as well. We'll also be sending a follow-up email with references to helpful resources and links to each after the event. So with that, I'd like to thank everyone again for attending today's webinar. We'll see you at the next one.